Testing 1, 2, 3. Jalan videonya tak? Testing 1, 2, 3. Suara dengar tak? Dengar. Like ke biji. Testing 1, 2, 3.
And she cries when I say she's up in the good times.
Suara dengar tak?
She's down
Dengar.
whenever
Like ke
I'm
biji.
discouraged. I tell her things that I want to do, but girl, she doesn't know about you. I can tell her my troubles. She makes them all seem right. I can make up excuses not to hold her of night. We can talk of tomorrow and tell the things that I want to do, but girl, how can I tell her about you? How can I tell her about you? Girl, please tell me what you do. Everything seems right whenever I'm with you. So girl, won't you tell me how to tell her about you? How can I tell her I don't miss her whenever I'm away? How can I say it's you I think of every single night and day? But when is it easy telling someone with you? But girl, help me tell her about you. How can I tell her about you? Girl, please tell me what everything seems right whenever I'm with you. stuck on you. I got this feeling down deep in my soul that I just can't lose. Guess I'm on my way. Needed a friend in the way I feel now. I guess that I'll be with you to the end. Guess I'm on my way. I might be glad to stay. I'm stuck on you. Been a fool too long. I guess it's time for me to come home. Guess I'm on my way. So hard to see that a woman like you could wait around for a man like me. Guess I'm on my way. I might be glad to stay. And I know just where I'm going.
Selamat pagi semua kepada para peserta. Pengumuman mesra. Para peserta yang dihormati, bagi makluman anda, satu link YouTube secara langsung, live, akan dipaparkan di ruangan chat box. Anda bolehlah berkongsi link dengan rakan-rakan yang turut berminat untuk menyertai kursus kita pada hari ini. Peringatan juga kepada para peserta, sebarang pertanyaan, kemusykilan sepanjang sesi ceramah bolehlah diajukan di ruangan chat. Jika masa mengizinkan, penceramah kita akan cuba menjawab kemusykilan anda pada akhir program kita pada hari ini. Perhatian juga kepada para peserta, diminta agar memastikan telefon bimbit anda di mode silent untuk memastikan kursus berjalan lancar. Tanpa melengahkan masa, ayo kita mulakan kursus kita pada hari ini. Salam sejahtera dan salam madani diucapkan kepada Miss Mazlinda Mahadzir, Ketua Jabatan ORL selaku penasihat kursus penjagaan tracheostomi peringkat Hospital Putrajaya 2023 kali yang ke-12. Anjuran Jabatan ORL HNS Hpj. Mr. Lim Wei Shun selaku penyelaras kursus, para penceramah jemputan yang dihormati, konsultan-konsultan, pakar-pakar, ahli jawatan kuasa kursus, staf-staf ENT dan para peserta yang dikasihi. Bagi memberkati kursus kita pada hari ini, dijemput saudara PPP Azam untuk bacaan doa. Dipersilakan.
Okey, Assalamualaikum warahmatullahi wabarakatuh. Kita mula kita Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahirabbil Ar-Rahmanirrahim. Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Amin. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala ashrafil mursalin. Wa ala alihi wa ashabihi ajma'in. Allahumma innaka khalaqul azim. Innaka sami'ul alim. Innaka ghafurur rahim. Innaka rabbul arshil azim. Allahumma ya karim ya rahim. Ya Allah, cucurilah rahmat dan rahimmu ke atas majlis kami yang diadakan pada hari ini. Ya Allah, berkatilah ia dari awal hingga akhir. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azaban nar. Wa sallallahu ala sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Allahu akbar. Amin.
Terima kasih diucapkan kepada saudara PPP Azam. Tanpa melengahkan masa, kursus pada hari ini akan diteruskan dengan sesi ceramah yang pertama yang akan disampaikan oleh Dr. Atikah Zakaria. Topik beliau adalah Applied Anatomy of Trachea and Larynx for Adult and Pediatric. Dipersilakan. Terima kasih diucapkan kepada saudara PPP Azam. Tanpa melengahkan
Okay. All right. Assalamualaikum. Good morning, everyone. Welcome to the Trachea course. My name is Dr. Atika. I'm the medical officer of ENT department. So today I'll be start the morning lecture with the topic of applied anatomy of the trachea and larynx for both adult and pediatric. Okay, this is the outline of our presentation today. I'll be talking about the trachea, the anatomy of the trachea, the relations of the trachea, blood supply, drainage, innervation of the trachea, and I'll compare between the adult and pediatric trachea. And then moving to the second part of the presentation, which is about the larynx. I'll tell about the cartilages of the larynx, the muscles of the larynx, blood supply, drainage, innervation of the larynx. Then I'll show some photo and videos of the larynx and trachea. And again, a comparison between adult and pediatric larynx. So we'll start with the trachea first. This is the picture of the trachea. So trachea is actually a non-collapsible white tube forming the beginning of the lower respiratory tract. It's actually capated because of the C-shaped cartilaginous rings in its wall. And you can see from the cross-section of the trachea, the cartilages are actually deficient posteriorly. This is the cartilage ring. Posteriorly, there's no cartilage ring because it's made up of the trachealis muscle, also the fibrous tissue. Why is this so? Because the soft posterior wall actually allows expansion of the esophagus, which is located posterior to the trachea, to allow the passage of the food. And the length of the trachea is about 10 to 15 centimeters for adult. And the upper half is actually lies in the neck, and while the lower half in the superior mediastinum. The size of the trachea, external diameter in adult ranging roughly about 1.5 centimeter in 2 cm. And in the first year of life, the diameter is only about 3 mm. Okay, so trachea begins at the lower border of the cricoid cartilage, which is opposite the C6 level. This is the cricoid cartilage, level C6. This is the trachea. And trachea actually runs downwards and slightly backwards in front of the esophagus, following the curvature of the spine. In the neck, trachea actually comparatively superficial. So it actually allows us to do our procedure, the tracheostomy. Okay. Relations of the trachea. So we're talking about the anterior, what's in front of the trachea, posterior, behind, and lateral, the sides of the trachea. So anteriorly, so see from outside, actually skin and superficial fascia, and then there's investing layer of the deep cervical fascia, sternocleidomastoid and sternothyroid muscles, the pretracheal fascia, the inferior thyroid vein, isthmus, and also left brachiocephalic vein. Posteriorly, there is an esophagus, recurrent laryngeal nerve, which is located in the tracheoesophageal groove, and also longus colli. Laterally, there's thyroid glands and the common carotid artery. So this is a picture of the relations of the trachea. Like I said, this is the trachea. In front of it, there's an isthmus of the thyroid. There's inferior thyroid vein running in front of the trachea. There's left brachiocephalic vein, this one. So anterior to the trachea. Okay. So behind the trachea, there's recurrent laryngeal nerve. Recurrent laryngeal nerve actually runs behind the trachea in between, in the tracheoesophageal groove. Naturally, there's the thyroid gland and the common carotid artery. This is the left common carotid artery, and this is the right common carotid artery. Okay. All right, then talking about the blood supply, drainage, and innervation of the trachea. Trachea is actually supplied by the branches from inferior thyroid arteries, and it drains into the left brachiocephalic vein. Lymphatic drainage, trachea drains into the pretracheal and paratracheal nodes. As for the innervation, they have two, parasympathetic nerve and sympathetic nerves. For parasympathetic nerves, they are from the vagus and recurrent laryngeal nerve, in which they supply the sensory and secretomotor function to the mucous membrane and motor function to the trachealis muscle. Sympathetic nerves is from the cervical ganglion, in which it supplies the vasomotor function, supplying the smooth muscle and blood vessels. Okay, the comparison between adult and pediatric. First, we can talk about the length of the trachea. For pediatric, the length is about 4 centimeter, diameter 4 mm. For adult, like I said, the length is about 10 to 15, 16 centimeter, diameter of 2 cm, so 20, 25 mm. In female, slightly lesser, about 1.5 centimeter. Okay, and then, sorry, the shape of the trachea. In pediatric, they are narrower, funnel shape. In adult, they are straight, tubular shaped trachea. And the cartilaginous rings in peds are more pliable, more soft compared to adult, in which it's more sturdy. And the trachea is more mobile in pediatric and less mobile in adult. And the submucosa loosely adhere to the cartilage for pediatrics, hence they are actually easily edematous compared to adult when the submucosa is adherent to the cartilage. All right, moving on to the larynx. So larynx is actually an organ for phonation and air passage, in which it acts as a sphincter at the inlet of the lower respiratory passage. So larynx starts above here. In adult male, larynx starts in front of the 3rd to 6th cervical vertebra. So we here epiglottis to level of cricoid. In adult female and also children, it lies actually at a little higher level, C2 to C4 level. All right, and in pediatrics, this larynx will begin to descend at the age of 2. So looking at this picture, another information about the larynx in pediatric, the epiglottis actually, the epiglottis tip rests behind the soft palate because it allows simultaneous breathing and suckling. From this picture, you can see the blue colored one is the air that coming from the nose into the nasopharynx, oropharynx, larynx, and then into the trachea. The red colored one is actually from the mouth, the milk feeding, and it goes laterally to the epiglottis into the esophagus. So the epiglottis actually helps to protect the larynx to prevent aspiration. That's why infant has a very good suck, swallow, breathe reflex. Okay, and then the cartilages of the larynx. So we have 9 cartilages, in which 3 are packed, so that makes 6 cartilages, and 3 are unpacked. So the unpacked cartilages are the thyroid cartilage, the cricoid cartilage, and the epiglottis. The packed cartilages are the arytenoid cartilage, corniculate cartilage, which is superior above the arytenoid, also the cuneiform cartilage. And these cartilages can be divided into hyaline cartilage and elastic cartilage. So the hyaline cartilages are thyroid, cricoid, and basal parts of the arytenoid cartilage. And these cartilages may ossify after the age of 25 years. For other cartilage, such as which is epiglottis, corniculate, cuneiform, and the processes of the arytenoid, they are elastic cartilage, so they do not ossify. Okay, this is actually a picture of it. Like I said, thyroid, cricoid, epiglottis. This is the arytenoid. This is the corniculate, cuneiform, actually at the lateral side of it. You can see from this picture. Okay. Moving on to the muscles of the larynx. We have 9 intrinsic muscles, but difficult to remember, but the cricothyroid, posterior cricoarytenoid, lateral cricoarytenoid, transverse arytenoid, oblique arytenoid, aryepiglottic, thyroarytenoid, thyroepiglottic, and vocalist. What's more important is we want to know the muscles that act on the larynx. So the muscles that elevate the larynx are the thyrohyoid and mylohyoid. The one that depress, causing depression of the larynx are the sternothyroid and sternohyoid. Okay, and then thyroepiglottic. This is the thyroepiglottic muscle. Okay, so as it names, thyroepiglottic, between the thyroid cartilage and the epiglottis. So when it contracts, it pulls the epiglottis, so it opens the inlet of the larynx. Every epiglottic is arytenoids and between arytenoids and epiglottis. So when it contracts, it causes closing of the larynx, closing inlet of the larynx. And posterior cricoarytenoid is the only abductor of the vocal cord. And the lateral cricoarytenoid is the lateral cricoarytenoid, transverse and oblique arytenoids. This is the adductor of vocal cord. Usually we do like this. This is the vocal cord. This is lateral cricoarytenoid. So when it contracts, the vocal cord will adduct it close. All right. Then cricothyroid is the tensor of the vocal cord. Thyroarytenoid and vocalis is the relaxer of the vocal cord. Okay. Blood supply, drainage, and innervation. Though it looks a lot, but it's actually quite easy to remember. You just have to divide into above the vocal folds, below the vocal folds. So arterial supply for above the vocal folds is superior laryngeal artery, which is a branch of superior thyroid artery. Below is inferior laryngeal artery. Venous drainage above by the superior laryngeal vein, drains into the superior laryngeal vein and drains into the superior thyroid vein. Below is drains into the inferior laryngeal vein. Lymphatic drainage above the vocal folds is they drain along the superior thyroid vessels into the antero-superior group of the deep cervical nodes, while below the vocal folds, they drain into the postero-inferior group of deep cervical nodes. And some may drain into the pre-laryngeal nodes by piercing the cricothyroid. For nerve supply, divided into motor supply and sensory supply. The motor supply, also easy to remember, recurrent laryngeal nerve supplies all the intrinsic muscles except cricothyroid, which is supplied by the external laryngeal nerve. And sensory, you can divide it into above and below the vocal folds. Above is by the internal laryngeal nerve, below is by the recurrent laryngeal nerve. Okay, so some facts to remember. The only intrinsic muscles that place on the outer aspect of laryngeal cartilage are actually cricothyroid. And cricothyroid is the only muscle supplied by external laryngeal nerve. And posterior cricoarytenoid is the only abductor of the vocal fold. So this is actually a life-saving muscle. So any injury to the muscles, because it's the only abductor to opens up the vocal cord. So if it's injured, so the vocal cord can be adducted, so the larynx is closed. So we may need to proceed with tracheostomy for those kind of patients. All right. So this is the videos and photo of the larynx. So showing the cadaver larynx from the sagittal view. This is anterior, this is posterior, the cervical vertebrae. This is the tongue, hyoid bone, E is the epiglottis, and then there's this vocal fold. This is the thyroid cartilage and cricoid cartilage. Okay. Okay, this is a video of FNPLS, flexible nasopharyngeal laryngoscope, that we did in our clinic. We often receive referral for airway assessment or vocal cord assessment. So this is what we see like. I'll show the video doing a running commentary on that. So this is the anterior view. This is the posterior view. So anteriorly, we can see the epiglottis. This is the arytenoid cartilage. This is the airy epiglottic fold, the false cord, and the true cord. Below that, subglottis and then trachea. Okay, this is the next video is a video of a flexible scope through a tracheostomy tube. Usually we see to assess the patency of the tracheostomy tube. Okay, going into the tube. All right, this is the trachea. You can see the trachea rings, and this is the carina going into the right main bronchus and the left main bronchus. All right. Okay, here is the videos of a flexible FNPLS of a pediatric patient. You can see the difference with the adult one. Okay, you can see the epiglottis, the shape is more, we call it omega shape. The airy epiglottic fold is actually a bit tight and short compared to adult. And the arytenoids, you can see the mucosa overlying the arytenoids usually a bit bulky with adults. Okay, and this is a video of a rigid endoscope, direct laryngoscope that we did under GA. You can see the video is a bit different compared to the flexible scope because the patient is under GA. So this the above one is the anterior. Below is the posterior. Unlike when we did a flexible scope in a live patient, this one is anterior, this is posterior. So in under GA, anterior is the other way around. And this is under GA going into the, this is the vocal cord going down, subglottis, and then there's the trachea. So this is a video of direct laryngoscopy and tracheoscopy of an infant patient. Okay, you can see the trachea rings. And it's actually more soft compared to adult. All right, so this is the comparison between the adult and pediatric larynx. You can see the shape of the larynx. In adult, they are cylindrical shape. In pediatric, they are funnel shape. And then most important is the narrowest part of the larynx. For adult, the narrowest part is at the vocal cords, while in pediatric, the narrowest part is at the cricoid ring. So any pressure here can compromises the pediatric patient. And then other than that, you can see the epiglottis in pediatric is floppier, U-shaped. In adult, the epiglottis is usually shorter and stiffer. And then other than that, the trachea. Trachea in pediatric is more flexible. All right. That's all from me. Thank you so much, everyone. Sure.
Terima kasih diucapkan kepada Dr. Atika atas sesi ceramah yang berinformatif tadi. Kursus kita akan diteruskan dengan slot ceramah yang kedua oleh Dr. Priya Darshini, Pegawai Perubatan dari Jabatan ENT. Topik beliau adalah Indications and Types of Tracheostomy Tubes for Adult and Pediatric. Dipersilakan.
All right, very good morning, everyone. I'm Dr. Priya Darshini, Medical Officer from ENT Department, Hospital Putrajaya. So I'll be presenting on indications and types of tracheostomy tube for adults and pediatrics today. So first, before we go into the indications and the types of tracheostomy tube, I would like to, today we'll be talking about the tracheostomy is basically being widely used for long-term management of wide variety of conditions. And this topic will discuss on indications of tracheostomy procedure. We'll also be talking about the components and functions of tracheostomy tube, which will also be elaborated and discuss on how to select the most appropriate tube. All right. As you can see on the image on the right side here, so tracheostomy tube is basically a rigid tube and designed in an angle which allows correct entry into the trachea and to facilitate the ventilation. And the main component to be considered during choosing a tracheostomy tube is to maintain airway, yet flexible to limit tissue trauma and maximize the patient effort and comfort. So why do we do a tracheostomy tube insertion or tracheostomy procedure for a patient? When do we decide? Is it just for fun? Is it based on patient's family request? Or is it based on primary team requests? So first we have to know, before we do any procedure, we need to know what is the indication of it. So the first indication is if there is involvement of upper airway obstruction, if the patient has prolonged ventilation. I will elaborate on each of these points later. For bronchial toileting or for elective procedures. So the first point, so for upper airway obstruction, normally a patient who has a neoplasm, meaning benign malignancy of oropharynx, larynx, of upper trachea, or there is any source of infection which is causing upper airway obstruction, such as tracheobronchitis or epiglottitis. When there's involvement of structural obstruction, such as severe laryngomalacia, bilateral vocal cord abductor palsy, subglottic stenosis, or tracheal stenosis. When there's trauma, which involves the maxillofacial fractures or any laryngeal injury, or foreign body obstruction. Next is, as I mentioned earlier, prolonged ventilation due to poor GCS recovery or failed extubation, meaning they've attempted to extubate the patient multiple times, still unable, so the patient is ventilator dependent, then we'll proceed. It's one of the indications for tracheostomy procedure. Bronchial toileting, removal of secretions in patients who have congestive cardiac failure or COPD with lung infection, or basically any patient that requires frequent bronchial toileting, then that's one of the indications to do a tracheostomy procedure. Next is elective procedures. Any patients who has major head and neck surgeries that may affect patency of airways, such as oral cavity or oropharynx tumor. This is common among dental patients, especially we get this kind of referrals from IKN, where we have patients where the surgical field involves the oral cavity and we're unable to intubate through the oral cavity or nasopharynx, then we will do a elective tracheostomy prior to proceeding to all these major head and neck surgeries, or prior to radiotherapy, because as we know, radiotherapy can cause immediate effect is it can cause edema of the airway. So any patients who has major head, oropharynx or oral cavities tumor that may need radiotherapy will be referred to us for a tracheostomy elective procedure. Or patients with impending airway collapse, meaning we are anticipating that this certain obstruction would lead to airway collapse, we will do a tracheostomy procedure as elective procedure. So next we'll be looking at the types of tracheostomy tube. So as a basic, so I'll be showing the real life tracheostomy tubes in a while, but this is the image of it. So as you can see, a tracheostomy tube comes with, it has an outer cannula, and there is a shaft here with a cuff attached distal to the outer cannula. There is a flange or neck piece, we call it. And this is a cuff tube, because there's a cuff there. We also have uncuffed tube, which I'll explain later. So it comes with, whenever there's a cuff tube, it comes with a cuff inflation line and it's attached to the pilot balloon. This is where we will deflate or inflate the cuff. This has an inner cannula and also an obturator. So outer cannula. So it's a main body of the tube which passes into the trachea. The inner cannula, which is this piece over here, it's a removable tube which passes into the outer cannula. So this goes inside the outer cannula and can be removed or replaced to promote clear airway. The cuff is a balloon at distal end of the tube which expands when inflated. So the inflation is done here via the pilot balloon and provides a seal between the tube and the tracheal wall. And cuff can be deflated or inflated to protect from aspiration or allow positive pressure ventilation. There'll be image coming soon to show, to explain further on that. So pilot balloon is an external balloon that's connected to the internal cuff by inflation line. This is a flange, the neck plate. It supports the main tube structure and preventing it from entering into the trachea. And also, as you can see here, there's some codings here that's written, that will be written on all the tracheostomy tubes. The tube code, size, type is often demonstrated on neck plate. So sometimes when we have referrals of patients who is on tracheostomy tube, but we don't have proper documentation what kind of tracheostomy tube inserted, and sometimes they don't know what tube is it, they don't know whether it's fenestrated, unfenestrated, what size is it, they don't have the box available. So you can always look at the patient's tracheostomy tube. At the neck plate, they will give you adequate information for you to think about the management or how you're going to attempt to help this patient out. So for instance, it's written, this is the brand name Shiley, then it's written the internal diameter or the outer diameter. So it doesn't have to be a specific brand. You can always decide what tube the patient needs by knowing that if the current tube, if you can find out what is the internal diameter and outer diameter, that can already help you to decide on what is the other tube you have and try to manage whatever tube you have at the moment. So adult neck plate is normally a straight strip, and pediatric tubes have an angled plate to accommodate the shorter and the developing neck. As you can see, this is an adult one. This is a pediatric one. It's a size 3.5. And this is the inner diameter, outer diameter. So the types of tracheostomy tube, we'll be looking at metal tubes and plastic tubes, the cuffed and uncuffed tubes, fenestrated and unfenestrated, and single and double lumen. So this is a metal tube. It's made up of stainless steel, not commonly used. Why? Because it's expensive. It has its lack of connector to a ventilator, and it's a rigid construction. It's very rigid, and it's traumatic to the inner lumen of the trachea. It used to be, this is one of the pioneer species of tracheostomy tube that we have, but now we no longer use this. But we have an example today to show you. Next is a plastic tube. So you can see this is a tracheostomy tube. Before we go into the details, so it's a cuff tube. There's a cuff attached to the distal end of the tracheostomy tube. There's an inflation line. And there's a pilot balloon here. So from this image alone, you can see that this is a cuff tube. Okay, if you don't know what detail is it, you can see it's a size 8 tube. It's a cuff tube because there's a pilot balloon there. So that will tell you enough information that you need to know. So it's made up of PVC or silicone. It has a connector to anesthetic machine and ventilator. It's less traumatic to the trachea. And plastic tubes, it can be made with cuff, which we didn't have that facility when it comes to metal tubes. Next, we will look at whether it's cuffed or uncuffed tube. So from this image, this is an uncuffed tube. As the name explains, there is no cuff at the distal end. And this is a cuff tube, and the cuff is inflated. There's an inflation line, there's a pilot balloon. All right, so what's the difference between cuffed tracheostomy tube and uncuffed tracheostomy tube? So you use a cuffed tracheostomy tube when there's involvement. You have to give the patient a positive pressure ventilation and also airway protection. Why? So from this image here, you can see there's a tracheostomy tube that goes, this is the stoma, the tube is, this is the airway here, this is the epiglottis, this is the larynx up there, this is the vocal cords. So the inhaled air goes into the tube and the exhaled air comes back out through the tube itself. So when there's a cuff, right, there is no leakage of the air into the laryngeal structures. So you can ventilate the patient. If you don't inflate a cuff in a patient who is ventilator dependent or is on positive pressure ventilation, what will happen is the anesthetic team will tell you we can't ventilate the patient. That means that it's either the cuff is faulty or there's some leakage that's happening. So there's not enough pressure to ventilate the patient. So uncuffed tracheostomy tube does not need ventilation and there's no aspiration risk. Aspiration also is one of the indications to use a cuffed tracheostomy tube. Because aspiration means basically there is sipping of fluid into the airway. So when there's a cuffed tube here, it will prevent it from going into further down into the airway. It only involves the upper trachea. Another image here, you can compare image A, this is a cuffed tracheostomy tube. Image B is a fenestrated tube, which I'll explain later. And image C is an uncuffed tracheostomy tube. So from the image, you can see in image A, the air goes into the tracheostomy tube. There's a cuffed tube, so the airway, the inhale and exhale air passes through the tube itself. But you see in image C, the air goes in because there is no cuffed tube. There's no seal there between the tube and the trachea. The air seeps through the larynx and the patient can breathe through the mouth. So this shows you why do you need a cuffed tube for a patient who needs positive pressure ventilation, and uncuffed tube is where patient is not on any ventilators. That's why normally post-op, after tracheostomy is done, if patient is off ventilator, we will deflate the cuff because it doesn't need a positive pressure ventilation. And there's also complications of persistent inflation of the cuff. We'll explain later. Once again, this image, you can see the left side is a patient with a cuff tube. And on the right side is a patient with a cuffless tube. So the airway goes, this is a tracheostomy tube here. So the air goes in, ventilates the patient, comes back out through the same space. A cuffless tube, the air goes in, but it seeps through the larynx and the patient able to breathe through the nose. So for intubated patients, you will need a cuff tube. This is the difference that will tell you when you use a cuff, when you use an uncuffed tube. Next is a fenestrated tube and non-fenestrated tube. So fenestration itself means an opening. So you can see here, the image above, the shaft here, the outer cannula, there's a hole there, there's a fenestration there. A non-fenestrated tube, as the name explains, there is no fenestration there. So what is the purpose of a fenestration in a tracheostomy tube? It's a small hole or multiple holes in the shaft of tracheostomy tube. It allows increased airflow through the upper airway. Mainly is to able to vocalize. And you need to use an inner cannula with fenestration also to be able to vocalize. Okay, so here. So this is, okay, for instance, if this tube, it's a non-fenestrated tube, the air goes in, the air goes out. But when there is a fenestration, the air can seep into the larynx. But again, if it's normally a fenestrated tube is only available in a long-term tube. We don't use it in a tube that is short-term usage. So what happens is when the airway goes out, the patient able to vocalize. So if you're suspecting, you're expecting your patient to be allowed to vocalize, or there's no any tumor that's going to seep through the fenestration, you can use a fenestrated tube for your patient. But if it's a patient with poor GCS recovery, you're not expecting the patient to recover anytime soon, then you don't risk it by giving a fenestrated tube, because I'll explain on the complications of fenestration. This image also, you see the fenestration, what it can do, sometimes it can cause trauma as well. So when there's trauma, there'll be granulation formation due to the trauma to tracheal wall. This image here. So this is a flexible scope done through the tracheostomy tube. So as you can see, there's a fenestration here. And you can see a granulation tissue that's coming in from the fenestration. This is due to trauma to the tracheal wall. So this granulation tissue formation, it's coming in. This is quite small. Sometimes what happens is the granulation tissue can almost 90% to 100% obscure the whole airway. So that's when we come with complications. Suddenly patient, you're unable to extend the suction tube. You can expect this as well. Then you need to find out whether the patient is on fenestrated tube or not. So this will give you an idea what can happen. Next is single lumen versus double lumen. So as the name explains again, single lumen tube has only one cannula that stays in situ throughout its use. But it has increased resistance to secretion adhering to tube, which means a single lumen tube, it doesn't have an inner cannula. It's just one single outer shaft. So what happens is when you want to clear the secretion, you don't have anything to remove and wash it and put it back. So it's almost suction dependent. You need a suction machine when the patient is on a single lumen tube. Whereas a double lumen tube, you can see this is the outer cannula, this is the inner cannula, this is the obturator. The inner cannula will be inserted into the outer cannula. So when you need to wash or clean the secretions, you don't require suction machine. You can remove the inner cannula, wash it, and you replace it back. Double lumen tube has inner cannula, which will assist the cleaning and reduces the risk of tube occlusions and the frequency of tube changes, which causes discomfort and trauma to the stoma site. And the presence of inner cannula will reduce the lumen by approximately 1 to 1.5 mm, which means it reduces the diameter of the outer cannula. So you have to use a slightly smaller suction than you regularly use. Next is adjustable flange tracheostomy tube. As the name explains, the flange is adjustable. So so if you look at this picture here, by the look of it, it looks slightly longer than a regular tracheostomy tube. It's a cuff tube, there's a balloon, there's an inflation line, there's a balloon there. And this is an adjustable flange. So it's a standard tracheostomy tube, have a standard curve, but this adjustable flange tube is extra long tube compared to the regular. And it has an adjustable flange that allows variable tube length and may be used in patients with larger neck. Why do you use adjustable flange? Is to increase the distance between the tracheostomy stoma at skin to the tracheal opening, such as when you're dealing with obese patient or edema. So there's two indications when you use adjustable tracheostomy tube. One is there's an increase in distal length, which means distal to the tracheostomy tube, there's a tracheal obstruction, you're suspecting a tracheomalacia or low-level tracheal stenosis. So you have to insert a longer tube to surpass this obstruction. So that's when you use the adjustable flange. Or there's an increase in proximal length, such as increase in pretracheal space, in obesity or enlarged thyroid or kyphoscoliosis. Next, we'll be looking at neonatal and pediatric tube. So the sizes differ according to age group and weight among neonates and pediatric. One thing to highlight is due to small size of tube, there is no inner cannula in neonatal or pediatric tube. I'll show you a pediatric tube in a while. And the tube encouraged to be changed weekly to avoid buildup of secretions causing respiratory obstruction. If you realize, especially my NICU colleagues would realize that the pediatric tube, tracheostomy tube or neonates tube is we change it more often compared to adult tube. This is because to avoid buildup of secretions. And silicone tube is recommended to allow mucus pass more effectively and reduce adherence of secretions to the tube space. Why do we normally a pediatric tube or a neonate tube comes uncuffed? Because it's delicate tracheal structure around it and there's narrow cricoid ring. Right. So before, okay. So now I'll be showing the examples of the tracheostomy tubes. So as I mentioned earlier, this is a metallic tracheostomy tube. As you can see, this is the flange. This is the neck piece. I'll show. So this is a tracheostomy tube. This is how it looks like for those who have not seen it. Okay. So this is a neck piece. As you can see, I don't know, there's some information that's written here. The inner diameter, the outer diameter, and the tube size is written here. It comes with a cuff here. This is the inflation line. And it comes with a pilot balloon here. And from here, it shows whether, it shows the size of the tube. So before you insert any tracheostomy tube, first of all, you have to check whether the cuff is functioning or not. So you take a 10cc syringe. Let me inflate and see. Right, so this is how a tracheostomy tube, cuff tube looks like, yeah? So it will be inserted in and it's a cuff tube, all right. So when you deflate it, you want to deflate the cuff, you deflate here. So it gets deflated, all right. So this is an uncuffed tube. As you can see, this is the opening of the trachea. This is the neck plate. You can see this is the shaft here. There's no cuff here. All right, and this is a single lumen because we don't have inner cannula for this tracheostomy tube. This is a pediatric tube. As I mentioned earlier, it's very, very small tube. This is size 3. We have size 3, 3.5, and 4. If you compare the adult tube and the pediatric tube, it's really, really tiny. That is why it doesn't come with the inner cannula. Mostly, even if it's a long-term tube, it doesn't come with the inner cannula because the shaft is really small. The inner diameter is really small. Okay, so this is the most common tube I think all of us know. So this is a double lumen tube. This is what we call a Shiley tube. I think most of you know it that way. So this is a tracheostomy tube. This is a neck plate here. It's written here, CFN. As I said, most of the data that you need comes on the tube. It means it's cuffless, it's fenestrated. And here you have the inner diameter and the outer diameter that's written here. So as the name explains, there is no cuff and there is a fenestration here. Right. So this is the inner cannula. So when you change a patient to a long-term tracheostomy tube, you change them into a double lumen tube so that when they go home, we were taught how to do a trachea care. They can remove the inner lumen and they can clean it and they can replace it back. And if you want to allow the patient to vocalize, the inner cannula has to have a fenestration tube. So when the patient wants to vocalize, they put in an inner cannula which has a fenestration in, and when they close here, they'll be able to vocalize because the air will escape through the larynx, through the upper airway. So this is an adjustable flange. As I explained, it's much longer than a regular tracheostomy tube. This is a regular tracheostomy tube. This is much longer. It comes with an adjustable flange. So how do you adjust is, we'll go further on this during the practical session, but just roughly showing you guys. So this is how it goes. So this will help us we can adjust the length, how far we want the tube to be. All right. All right, that's all from my side. Any questions? Okay. All right, thank you so much.
Terima kasih diucapkan kepada Dr. Priya atas sesi ceramah yang berinformatif tadi. Moga para peserta bermanfaat daripada sesi tadi. Sebarang pertanyaan ataupun kemusykilan boleh dah diletakkan di ruangan chat box dan kami akan cuba membalasnya pada sesi akhir petang ini. Para peserta, kita akan berehat seketika dan sesi ceramah seterusnya akan bermula tepat pada jam 10.30 pagi. Harap maklum.
It's late in the evening. She's wondering what clothes to wear. She puts on her makeup and brushes her long blonde hair. And then she asks me, do I look alright? And I said, yes, you look wonderful tonight. We go to a party and everyone turns to see this beautiful lady that's walking around with me. And then she asked me, do you feel alright? And I said, yes, I feel wonderful tonight. I feel wonderful because I see the love light in your eyes, and the wonder of it all is that you just don't realize how much I love you. It's time to go home now. I've got an aching head, so I give her the car keys and she helps me to bed. And then I tell her, as I turn out the light, I say, my darling, you are wonderful tonight. Oh, my darling, you are wonderful tonight.
There's a love, a certain kind of love it never showed on me. I want my life to live with you, to live with you. There's a everybody says to do is never little thing. But what does it bring if I ain't got you? Ain't got you. Baby, you don't know this life. Baby, you don't know this life. To love somebody, the way I love you. In my mind, I see you face again. And no frame of mind. You're so blind. I'm blind, so very blind. I'm a man. Can't you see what I am? I live and breathe for you. But what does it do if I ain't got you? If I ain't got you, baby, you don't know this life. Baby, you don't know this life. To love somebody, the way I love you. Oh, you don't know this life. Baby, you don't know this life. To love somebody, to love somebody, to love somebody. You don't know. To love somebody the way I love you. You don't know. You don't know. To love somebody, you don't know. To love somebody. To love somebody where I love you.
Thank you.
Everybody needs a little time away from each other. Even lovers need a holiday. Far away from each other. Oh, now it's hard for me to say I'm sorry. I just want you to stay. After all we've been through, I will make it up to you. I promise to. And after all that's been said and done, you're just the person. Couldn't stand to be kept away just for the day. from your body. Wouldn't wanna be swept away. It's hard to say. I just want you to know. Hold me now. I wanna tell you I'm sorry. I could never let you go. After all that we've been through, I will make it up to you. I promise to. And after all that's been said and done, you're just a part of me you can't let go. After all that we've been through, I will make it up to you. I promise to. You're gonna be the lucky one. Gotta take a little time to think things over. I gotta read between the lines in case I need it when I'm older. This mountain I must climb feels like a world upon my shoulder. Through the clouds I see love shine. It keeps me warm as life grows colder. In my life, there's been heartache and pain. I don't know if I can face it again. Can't stop it now. I've traveled so far to change this lonely life. I wanna know what love is. I want you to show me. I wanna feel what love is. I know you can show me. Gonna take a little time to look around me. I've got nowhere left to hide. It looks like love has finally found me. In my life, there's been heartache
She's up in the good times. She's down in the bed. Whenever I'm discouraged, I tell the things that I want to do. But girl, she doesn't know about you. I can tell her my troubles. She makes them all seems right. I can make up excuses not to hold her of mine. We can talk of tomorrow and tell the things that I want to do. But girl, how can I tell her about you? How can I tell her about you? Girl, please tell me what you do. Everything seems right whenever I'm with you. So girl, won't you tell me how to tell her about you? How can I tell her I don't miss her whenever I'm away? How can I say it's you I think of